Good morning, friends. In this session, I'll be discussing about the CA esophagus, right? The CA esophagus, and all the important points written in our notes. The first thing written here is before we understand what exactly the CA esophagus, carcinoma esophagus, we should understand few basic points. One is a surgical anatomy, right? Surgical anatomy. Now, the esophagus is divided, right? Divided into four parts or something like that. Okay, one is the first is cervical esophagus, right? You have got something known as cervical esophagus. Then you have got something known as upper thoracic esophagus. Then you have middle thoracic esophagus, and you have lower thoracic esophagus. So, why are we discussing about this surgical anatomy, the beautiful surgical anatomy? Because it has got a basic or important landmarks, okay, which we'll be discussing in the further sessions. So, the first point is a cervical esophagus. What is cervical esophagus and where from it starts? The cervical esophagus starts from cricopharynx to sternal notch. So if you observe carefully this diagram, right, this is incisors, okay, these are the lips, incisors. This is cricopharynx, okay. Now, the esophagus which is located, right, you know that the cricopharynx, the inlet starts from the cricopharynx muscle, right? You know that the part of inferior constrictor that we have already discussed. Now, the distance between the cricopharynx and the sternal notch, this is known as cervical esophagus. This is known as cervical esophagus. What is upper thoracic esophagus? Upper thoracic esophagus, it is nothing but it is a distance from sternal notch, right, to the lower border of the esophagus vein. Lower border of the esophagus vein, right? So that's the basic point. They can ask you whether it is upper and lower. So the line should come from here. This is the lower border of the. It is a lower border of the esophagus vein. Okay, so the sternal notch, from the sternal notch and the lower border of the esophagus vein, we have upper thoracic esophagus, right? What is middle thoracic esophagus? From the lower border of the esophagus vein to the inferior, right, to the inferior pulmonary vein, to the inferior pulmonary veins. So these are the inferior pulmonary vein. Understanding, right? So that is also the inferior border. So that is a middle thoracic esophagus. What is lower thoracic esophagus? Lower thoracic esophagus is the esophagus where the esophagus extends, okay, extends from where? From the inferior border of the inferior pulmonary vein to the, this is esophagus, this is gastro, right? Right, esophageal-gastro junction, right? GE junction. It is a gastroesophageal junction. Gastroesophageal junction. Now, if you observe carefully, below this junction, we this is known as abdominal esophagus. That we'll be discussing, right? Abdominal. But time being, we need to understand why are we discussing about this. So, if you take the distance, from the upper incisors, right? If you take the distance from there, now the distance is 15 centimeters. That's what you need to understand. 15 centimeters till the cricopharynx. Okay, from the cricopharynx to the sternal notch, it is 5 centimeters, right? 25. Now, that's all. Cricopharynx, from the cricopharynx to the sternal notch, okay, it is 5 centimeters, right? That you need to understand. That means from the upper incisors till the sternal notch, how much it is? It is 20 centimeters. So from the upper incisors to the cricopharynx, it is 15 centimeters. Sternal notch, just add 5, 20 centimeters. Esophagus vein, add 5, 25 centimeters. Inferior pulmonary vein, add 5 centimeters, that is 30 centimeters. From the inferior, and this is G junction, we have, that is our add 10, that is 40 centimeters. Okay, now If you look into this, if you look into the points here, now the sternal notch, if you observe carefully, the cricopharynx till the sternal notch, right? So sternal notch, and this is of if you observe, you have a 15 centimeters here, you got an 25 centimeters here. Okay, uh, this is the cervical esophagus. This is sternal notch esophagus. It is just 5 centimeters. This is of 5 centimeters. Cricopharynx sternal, it is of 10 centimeters. So it is of 10 centimeters here, 10 centimeters here. The 5 centimeters, 5 centimeters. Okay. So the total centimeters, the total, if you see, the thoracic esophagus is 20 centimeters in length. Right? How come it is 20 centimeters? How come? From where? The thoracic esophagus 20 centimeters. See, if you observe carefully, the lower esophagus is of 10 centimeters. You understanding? The middle esophagus is of 5 centimeters. Okay, you understanding? The upper thoracic esophagus is of 5 centimeters. So this 10, it is of 20 centimeters. That's all you need to understand. This is an abdominal esophagus. This is a cervical esophagus, that is of 5. Abdominal esophagus of 2 centimeters. Right? Hope you're understanding. Now, whenever you are discussing about in the further sessions, we need to understand you have got something known as you have a notes, okay, that we'll be discussing in detail. But time being, you understand the esophagus has got some nodes, okay, the stations. It has gotten 20 relaying stations. The first station, if you observe carefully the diagram here, it is of supraclavicular node. So the first station of the node is present at above the clavicle, supraclavicular node. The second is 2R, right upper paratracheal node. 2L is left upper paratracheal node. Next is 3P, posterior mediastinal node, right? 4R, it is an right lower paratracheal node. So 2 is the right upper paratracheal node, 4R is right lower paratracheal node, 2L is left upper paratracheal node, 4L is left lower paratracheal node. And the 5, if you look into the 5, you have aortopulmonary nodes. So if you observe carefully, it's a 5, right? It's a 5, aortopulmonary nodes. And 6 is anterior mediastinal nodes. 6 is anterior mediastinal nodes. The 7th is subcarinal nodes. So this is an important point which we need to understand. The subcarinal is at 7th station, Okay. The 8M middle parapharyngeal node, lymph node. 8L is lower esophageal lymph nodes. 9 is pulmonary ligament nodes. Okay. 10R is right tracheobronchial nodes. 10L is left tracheobronchial nodes. 15 is diaphragmatic nodes. Okay. 15 is diaphragmatic nodes. 16 is paracardinal nodes. 17 is left gastric nodes. 18 is common hepatic nodes. 19 is splenic nodes. 20 is celiac nodes. Right? So remember that we have 20 stations to be discussed. Okay? We'll be discussing each and every point in detail. But time you need to understand the carcinoma, the cervical esophagus has been divided into cervical, the esophagus divided into cervical esophagus, upper thorax, middle thorax, lower thorax, abdomen. 5, this is 2, 5, 5, 10, that is 20 centimeters. That's all you need to understand. Okay, from there, if you have above 15, then you have 15, then you have 20, 25, 30, and 40. Okay. Now it's time to understand a few basic points. Okay, it's time to understand a few basic points of a CA esophagus, right? CA esophagus. So let me read the points, okay, so that the important points from the notes and from the substance and from other different sources. So epidemiology, okay, epidemiology. If you look into the epidemiology, this CA esophagus, okay, it is an 8th most common cancer, okay, 6th most common cause of cancer death, okay, and squamous cell carcinoma, it is of 80% more than adenocarcinoma. Okay, now it is increase in recent years due to lifestyle changes like obesity epidemics. And squamous cell carcinoma most common in esophageal CA belt. Okay, in esophageal CA belt, like in Central Asia, Northern Iran, then Himalayan province of China. Okay, and it's also written that in epidemiology, if you look into this middle esophagus is the most common site. Okay, most common site in India, and the most common cancer in India in the middle. It is the most common site. It is present in the middle thorax. That is squamous cell carcinoma. If they ask you the world also where is the most common cancer in the thorax, in the esophagus, it is the middle. Most common type of cancer in the world or India, it is squamous cell carcinoma. In the lower one third, it is a western. In the western, the most common. In the western, the most common site of an esophageal carcinoma. It is the western, where it is most common site. It is site in the lower one third. Okay, and what type of cancer it is? Adenocarcinoma. And where is the most common site of benign 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 growth? It is a lower one third. And what is the most common benign growth? That is leiomyoma. Now, both squamous cell carcinoma and remember the adenocarcinoma are more common in males. So that's the basic points which we need to discuss. One is the eighth most common cause and sixth most common cause of death. Is most known as squamous cell carcinoma more than adenocarcinoma. Then, which I have already discussed, the squamous cell carcinoma most common esophagus CA belt, that is Himalayan province of China, Central Asia, Northern Iran. Now that's all. That's the first brief epidemiology of CA esophagus. Now we need to understand, which I have already discussed. There are two cancers which are important. One is squamous cell carcinoma and the adenocarcinoma. Now, what are the risk factors of the squamous cell carcinoma? The risk factors of squamous cell carcinoma are, let me read, then we'll discuss how do you remember this. One is smoking. Smoking causes a squamous cell carcinoma. Smoking increases it. Then you have alcohol, genetic polymorphism, then history of aerodigestive malignancy, then hot beverages, N-nitroso containing foods, betel nuts, fungal toxin or virus, large corrosive stricture, then you have mediastinal radiation history, Plummer-Wilson syndrome, okay, Tylosia, achalasia cardia. These three are pre-malignant conditions or squamous cell carcinoma. Micronutrients deficiency like vitamin A, E, C, B1, B2, selenium, Mn, molybdenum, magnesium. The Bloom's syndrome, Fanconi syndrome, low socioeconomic in the males. So how do you remember this? Okay, so my friend Clampsana. Okay, what is B here? B is a Bloom. It's a Bloom syndrome. What happens in the Bloom syndrome? Bloom syndrome, there's increased DNA break. That is genomic stability. Increased DNA break. Now one more. What is one more B here? B is a betel nut. Okay. One is Bloom. Next is betel nut. What is F? F here? F is Fanconi syndrome. What happens in the Fanconi syndrome? There is a defect or failure in the proximal tubular. Okay. Or proximal tubular in kidney. So it fails to absorb the glucose, amino acid and phosphate. Amino acids. The first thing is B for Bloom's, right? You understand. B for Bloom's syndrome. Then your betel nut. F for Fanconi's. Good. Fanconi's. And okay. The next thing is what is C here? What is C? Okay. What is C? What is C? What is L? What is A? What is M? What is P? C is which I have already discussed, corrosive stricture, right? Corrosive strictures. Okay. Then what is L here? What is A? A for alcohol. Alcohol plays an important role. M is micronutrients deficiency, like vitamin A, E, C, B1, B2, selenium, Mn, Mo, Mg, manganese, molybdenum, magnesium, right? All this micronutrients deficiency also plays here. The next is Plummer-Vinson syndrome, right? Plummer-Vinson syndrome. And next you have what is S comes for smoking, also plays a vital role. Next one more A is achalasia cardia. What is N? N is nitroso containing foods, right? Nitroso containing foods. Then you have H is hot beverages, okay? Hot beverages, and history of erosive malignancy and history of mediastinal radiations. History of mediastinal radiations. What is one more F? F is Fancon is fungal toxins, okay? Fungal toxins, right? So let me refresh here. How do you remember this? What is B? B for Bloom syndrome. One more B for betel nut. What is F? F for Fanconi syndrome. One more F is fungal toxins or fungal virus. One is C, corrosive stricture. And corrosive stricture, it is more than, say example, a patient takes alkali, okay, he has a corrosive nature, there's a stricture formed in the esophagus, and after 40 years, more than 40 years, there's 1,000 times risk of cancer, okay, 1,000 times risk of cancer. Next is what is L, which I have already discussed. L is large corrosive, which I have already discussed, no, right? Next, low socioeconomic, L for low socioeconomic status. Then A for alcohol, okay, alcohol plays an important role. M for micronutrients deficiency, right, like vitamin A, E, C, B1, B2, selenium, molybdenum, magnesium, and manganese. P for Plummer-Vinson syndrome, okay, tylosia. What is S for? S, which I have already discussed. What is S? S is that's all. Selenium, which are all smoking. S for smoking. N is N-nitroso amino compounds, and N-nitroso amino compounds, where are those found? They are found in the smoking, like you have tandoori chickens, all this grilled and frying foods, okay. They also plays an important role in CA, esophagus, okay. Now, what is A here? What is H here? H, A and H is important. Okay, that's all we'll be discussing. Male, which we have already discussed. H is history of aerodigestive malignancy and history of mediastinal radiation. So what all the smoking done, this done, hot beverages. H for very important, hot beverages, history of aerodigestive malignancy and history of mediastinal radiation. So that's all you need to understand regarding the risk factors of squamous cell carcinoma. And in adenocarcinoma, what are the risk factors here? Let me read, then we'll understand how do you remember this. You have something known as Barrett's esophagus, then you have GERD and obesity, history of mediastinal radiation, same, and you have a smoking here, familial Barrett's esophagus, no alcohol here, high socioeconomic status, scleroderma, and male also. So how do you remember this? You have got something known as BROSS, BROSS. What is B for Barrett's esophagus? B for Barrett's esophagus, the familial Barrett's esophagus. What is G? G for GERD. Remember, G for GERD. Oh, so what is BROSS? BR, right? R is, or you have got something known as radiations, history of mediastinal radiations. What is O? O here. O is obesity. O is obesity. O, obesity and no alcohol. What is S for scleroderma? S for smoking. S for scleroderma. S for smoking. Then you have H have told high socioeconomic status. Then you have G, you have GERD. G for GERD. G for GERD. So that's all you need to understand regarding the risk factors, okay? The risk factors of squamous cell carcinoma and the risk factors of adenocarcinoma. Now, let us understand, okay? Let us understand Now we have got something known as precursors lesions. Okay, precursor lesions. Now for a squamous cell carcinoma, right? Squamous cell carcinoma. Now there is something known as a squamous dysplasia. That means if you look into the structure or the histology of esophagus, which I have already discussed, the lining of the epithelium, the lining of the mucosa, lining of the epithelium, the lining of mucosa, there is a squamous epithelium. Now, what happens here is because of these predisposing factors, it can be which I have already discussed, boyfriends, clamp, sanas. Okay, sana. In this, there is a continuous stimulation and there is an dysplasia. Dysplasia nothing but the cells of an abnormal cells are replaced there. That means the normal cells are replaced by abnormal cells. Now, initially, there'll be a mild dysplasia, then comes a moderate dysplasia, then severe dysplasia. Okay, then severe dysplasia. That's how the point precursor lesions are. Now, how the precursor lesions of the adenocarcinoma is, if you look into the Barrett's esophagus, now there is something known as non-dysplastic, okay, non-dysplastic intestinal metaplasia. That means you don't have any change in the cells here. Okay, now what happens? It's non-dysplastic. Now the barriers in Barrett's esophagus, as I have already discussed, the esophagus is lined by squamous epithelium, squamous non-keratinized epithelium, that is replaced by or that is metaplaced by. You have the cells, the intestinal cells. If you look into the intestinal cells, has gotten you got an goblet cells also, right? So there is a metaplastic columnar tissue is present at the in the esophagus. Now this is a low grade dysplasia. Then after the metaplasia, first you have a non-dysplastic intestinal metaplasia. Once the esophagus, the squamous cell epithelium is replaced by the intestinal epithelium, then the point starts where the low grade dysplasia, then the high grade dysplasia, then the esophageal adenocarcinoma is formed, right? So that's how the precursor relations, or that's how these points are found. Now we need to understand, which we are discussing about the risk factors of the CA esophagus, right? The risk factors. We should also understand the protective factors for the squamous cell carcinoma, the adenocarcinoma. Now, what are the structures which protect the squamous cell carcinoma and the adenocarcinoma? The first is for the squamous cell carcinoma, fresh fruits and vegetables. The fresh fruits and vegetables, they decreases the chances of the esophageal carcinoma. Okay, next you have NSAIDs. Okay, you have NSAIDs and aspirin also, right? NSAIDs and aspirin, they decreases the squamous cell carcinoma. They decreases squamous cell carcinoma. They also decreases the adenocarcinoma because they decreases the reflex, right? They decreases. Okay, NSAIDs and the aspirins, they decreases the discussed squamous cell carcinoma, adenocarcinoma. Now, if you observe, H. pylori has got no effect on squamous cell carcinoma, but H. pylori, that decreases the chances of adenocarcinoma, or it acts as a protective mechanism for adenocarcinoma. How does it act? It produces something known as CAG-A toxin. Okay, this CAG-A toxin, it forms, what does it do? It forms an atrophic gastritis. Remember, it forms from atrophic gastritis. Once there is an atrophic gastritis, there's a decreased acid reflux. Once there is a decreased acid reflux, there's a decreased reflex going to this from the stomach to the esophagus. So there is a decreased adenocarcinoma. That is how the H. pylori, because of release of CAG-A toxin, which forms an atrophic gastritis, they decrease the acid reflux, they decrease in adenocarcinoma. Now, how this PPA forms? The PPA increases, right? What does it do? It increases the stimulation. The proton pump inhibitors, they increase the stimulation of gastrin production. Once there is an increase of production of gastrin production, then this they ultimately Barrett's esophagus, then ultimately cancer forms. Okay, so that's how the protective, how it is, how protective, or how it increases. The PPA is also it increases. Okay, the adenocarcinoma. Now let us understand uh, that's all the basics about the epidemiology. That's all the basics about the risk factors. That's all about the basics of precursors lesions which we need to understand. Now let us understand the proper how the cancerous conditions, how the patient presents with. Now the patient's presence with the patients comes with an difficulty in swallowing, okay, and the difficulty swallowing from weeks to months. You have a fatigue, you have a regurgitation comes out, dysphagia, difficulty in breathing, you have anemia. Now, the dysphagia is first for the solid fluids. When it is for solid fluids, the patient try to chew very hard, and it is she now the later difficult to soft food than to the liquid. The patient also comes with an complaints of hoarseness because of any laryngeal nerve involvement. Patient also can have a cough if there is a tracheoesophageal fistula, right? Tracheoesophageal fistula. Now, patient can also have a weight loss because and weight loss can be because of it can be because of any other obstructive esophageal lumen. So we need to look for supraclavicular and cervical adenopathy. Cervical adenopathy. The patient can have anemia, chronic blood loss. Patient can have hypoproteinemia, malnutrition. Patient can have hypercalcemia, abnormal liver function because of any distant metastasis. Because of any distant metastasis, they can have they can have the other systemic involvement also. Okay, so that's what is planning to tell you. So the clinical presentation, the patient can have dysphagia, and this dysphagia is progressive from solids to liquid. Okay, and dysphagia is if it is more than one third of the circumference is involvement. Then you have odinophagia, regurgitation, cough, aspiration. Aspiration can happen if there is an tracheoesophageal, what you call it, tracheoesophageal involvement. Okay, aspiration can happen, and now the patient can have a chest, what you call is like a chest involvement. Okay, chest infections can happen. Hoarseness, that is a tumor infiltration of recurrent laryngeal nerve. Supraclavicular lymph nodes can also happen. So these are the clinical presentation which we need to discuss. Okay, right. Now let us understand the staging. Okay, staging of the esophagus. Staging of esophagus, and you have TNM staging. TNM staging. So the first thing is this is a section which tells about the histology. Okay, this tells about the histology about histology of what? It tells about the histology of the esophagus. So the first thing is this is a mucosa. Okay, you have a mucosa, and this is a what? This is a submucosa. Okay, this is musculus propria. Then it has adventitia. So in the mucosa, you have something known as epithelium and the basement membrane. Now say example. You have the patient. Oh, sorry, the what you call is like the cancer is present at the epithelium. Okay, till the basement membrane. Okay, till here. This is something known as, you call this as TIS, T in situ. Okay, it's in situ in the sense it is inside the epithelium. It has not come out. Okay, that is an that a TAS. Now it is malignant cells conformed to the epithelium by basement membrane. So it is present in the epithelium itself, but it is not come out. Okay, not come out. Next is something known as T1A staging. What is T1A staging? In the T1A staging, this cancer is limited or invaded the lamina propria and muscularis mucosa. It's a not propria, it is muscularis mucosa. Okay, that's all you need to understand. Mucosa. Next, you have got something T1B. In the T1B, you have got it invades a submucosa. Remember that mucosa is different, and you have a submucosa. Okay, mucosa. Below the mucosa is submucosa. So now this the structures. Okay, the structures which we need to understand. The T1A, then L, the one itself. It is invading the lamina propria and the musculus mucosa. T1B submucosa. What is T2? T2 invades the muscularis propria. There's two. You can just remember, since the muscles have two, that is longitudinal muscle and the circular muscle. It's two. Just remember the T2, right? T2. Next you have T3. If you have adventitious, inverse adventitia, that's T3 stage, TNM. Okay, T3. Now, what is T4A? T4 is spreaded to the removable structures like pleura, pericardium, esophagus vein, peritoneum, right? A diaphragm, which can be removed. And what is T4B, which cannot be removed? Like you have an aorta, vertebral bodies, airways, trachea, which you cannot remove. That's what you need to understand. One is aorta, right? One is aorta, one is vertebral bodies, okay, vertebral body. Then you have airways like trachea. Trachea you cannot remove, vertebral body you cannot remove. You cannot remove in the aorta also, right? Aorta. So that's all about the T4B, T4A, T3, T2, T1B, T1A. Then you have got something known as TIS, high grade dysplasia, where now you need to understand the malignant cells confined to epithelium layer. What TX? It is primary tumors cannot be assessed. Remember that. What is T staging? TX, that is primary tumors cannot be assessed. Cannot be, primary tumors cannot be assessed. Next we have N. What is NX? Is regional node cannot be assessed. NO, regional lymph node, no regional lymph node metastasis. N1 is 1 to 2 lymph nodes or regional nodes. N2 is 3 to 6 regional nodes are affected. N3 is more than 7 regional nodes are affected. What is M here? M is metastasis. MX is metastasis cannot be assessed. Metastasis cannot be assessed. M1 is no distant metastasis. M1 is distant metastasis. And you have got something grade G. X means cannot be assessed. G1 is well differentiated. D2 is moderately differentiated. And you have G3 is poorly differentiated. What is L here? L is the location and it is applicable to the squamous cell carcinoma only. LX is location unknown. Upper, right, upper, it's from the cervical where you call is carnal till the esophagus to inferior pulmonary vein to gastroesophageal junction. So the basic points, these are the important points, these are the basic points which we need to discuss. Let us continue in the next session. Thank you.